You're doing everything right. At least that's what you've been told. You go for your checkups. You listen to your doctor. You try to eat better. Maybe you've even cut down on fat because that's what you've heard your entire life. Fat is the enemy, cholesterol is dangerous, and lowering it is the key to protecting your heart. And every time you leave the clinic, you carry the same reassurance. Everything looks okay. Just keep doing what you're doing. But then something doesn't make sense, because despite all of that, people still end up with blocked arteries. They still end up needing stents. They still have heart attacks, sometimes completely out of the blue. And when that happens, the question that quietly lingers is this: if everything was under control, what went wrong? To answer that, when we need to look at something most people never actually see, the inside of an artery, not as a diagram in a textbook, but as a living, changing biological system. Because the story you've been told about heart disease is not entirely wrong, but it is incomplete. For decades, the dominant idea has been simple. Cholesterol builds up inside arteries like grease inside a pipe. Over time, the pipe narrows, blood flow decreases, and eventually something catastrophic happens. It's a clean, satisfying explanation. But modern cardiovascular research has revealed something far more complex and far more important. According to large bodies of research summarized by organizations like the American Heart Association, atherosclerosis, the process that leads to plaque buildup is not just a storage problem, it's an inflammatory disease. And that one shift in understanding changes everything. Because now, instead of asking, how much cholesterol is there, we start asking a much more important question. What is the body reacting to? Inside your blood vessels is a thin, almost invisible layer of cells called the endothelium. It's only one cell thick, but it plays a critical role. It controls how your blood flows, how your vessels expand, how they respond to stress, and how they maintain balance. When this layer is healthy, everything works smoothly. But when it becomes irritated, through a combination of factors like high blood pressure, smoking, chronic stress, insulin resistance, or oxidative stress, it begins to malfunction. Tiny cracks and dysfunctions appear. Not enough to feel, not enough to notice, but enough to trigger a response. Your immune system steps in. And this is where things start to shift. White blood cells, particularly macrophages, move into the arterial wall to deal with what the body perceives as damage. Their job is simple: clean up and leave. But what they encounter determines what happens next. Floating through your bloodstream are particles called LDL, low-density lipoproteins. These particles carry cholesterol, which your body actually needs for hormone production, cell membranes, and many other essential functions. LDL itself is not inherently harmful. The problem begins when LDL becomes chemically altered, specifically when it becomes oxidized. Oxidation is a process that occurs when molecules interact with unstable compounds, known as free radicals. This can happen due to poor diet, environmental toxins, smoking, chronic inflammation, or metabolic dysfunction. When LDL becomes oxidized, it changes shape, and that change makes it recognizable as dangerous to the immune system. Macrophages begin to consume these oxidized LDL particles. At first, this is protective, but unlike normal cleanup processes, this one doesn't shut off. The macrophages keep absorbing more and more oxidized LDL until they become overloaded. They swell, lose function, and transform into what researchers call foam cells. These foam cells don't leave. They get trapped within the arterial wall. They accumulate. They signal for more immune activity. They release inflammatory molecules. And over time, this growing cluster becomes what we call plaque. This entire process, documented extensively in cardiovascular research, including studies published in the Journal of the American College of Cardiology, is not passive, it's active. It's biological, it's ongoing, and most importantly, it's driven by more than just cholesterol levels. This is why two people with similar cholesterol numbers can have completely different outcomes. One may develop significant plaque, the other may not, because the real drivers lie deeper in inflammation, oxidative stress, and how the body processes and responds to lipids. This also explains something that has puzzled both patients and clinicians for years. Why does plaque continue to progress in some people even when their cholesterol is controlled? Part of the answer lies in the difference between quantity and quality. Not all LDL particles behave the same way. Some are larger and less reactive. Others are smaller, denser, and more prone to oxidation. Research increasingly points toward markers like ApoB and LDL particle number as more accurate predictors of risk than total cholesterol alone. At the same time, inflammation plays a central role. High-sensitivity C-reactive protein, or HSCRP, is one of the markers used to measure systemic inflammation, and elevated levels have been consistently associated with increased cardiovascular risk. This connection between inflammation and heart disease has been so strongly supported that major clinical trials, referenced in journals like the New England Journal of Medicine, have shown that reducing inflammation, independent of cholesterol reduction, can significantly lower cardiovascular events. So now we have a clearer picture. Plaque doesn't just form because cholesterol is present. It forms when cholesterol becomes damaged and when the arterial lining is compromised and when the immune system remains chronically activated. But there's another layer to this, because once plaque forms, it doesn't simply sit there. It evolves. Over time, calcium begins to deposit within the plaque. This process is part of the body's attempt to stabilize the lesion, to prevent it from rupturing. In some ways, calcification can be protective, but it also makes the arteries stiffer, less flexible, less responsive, and this stiffness contributes to increased blood pressure and reduced vascular health. The regulation of calcium in the body is complex, involving multiple systems, including proteins like matrix Glay protein, which require vitamin K to function properly. Research in journals such as Thrombosis and Hemostasis has explored how vitamin K-dependent processes influence vascular calcification, though this remains an area of ongoing study rather than a simple nutritional fix. At this point, it becomes clear why quick solutions rarely work, because this is not a single problem. It's a network of interacting processes. Lipid metabolism, immune activation, oxidative stress, endothelial function, calcium regulation, all happening simultaneously over years or decades. So what actually helps? The answer is not a single food, a single supplement, or a single intervention. It's a pattern, a consistent alignment of behaviors that support the system as a whole. Diet plays a central role, but not in the way many people think. It's not about eliminating all fats. In fact, Large-scale studies like the PREDIME trial have shown that diets rich in healthy fats, particularly extra virgin olive oil and nuts, are associated with reduced cardiovascular events. These findings align with broader recommendations from the World Health Organization, which emphasize dietary patterns rather than isolated nutrients. Vegetables, especially those rich in nitrates like leafy greens, support nitric oxide production, which helps blood vessels relax and function properly. Fruits rich in polyphenols provide antioxidant support, potentially reducing oxidative stress. Whole, minimally processed foods help stabilize blood sugar and reduce inflammatory burden. Physical activity improves endothelial function and insulin sensitivity. Sleep regulates hormonal balance and recovery. So stress management reduces chronic inflammatory signaling. And in many cases, medical therapy, including statins, plays an important role. Despite ongoing debates, the evidence supporting statins in reducing cardiovascular risk is substantial, particularly in high-risk populations. They don't just lower LDL, they also have anti-inflammatory effects. The key is not to reject one approach in favor of another extreme. It's to understand that cardiovascular health is multifactorial, and the most effective strategies address multiple pathways at once. If there is one takeaway from all of this, it's this. You are not just managing cholesterol, you are managing a system, a dynamic, responsive, complex system that reflects how you live, eat, move, and recover. And perhaps the most powerful shift you can make is moving from a narrow focus on numbers to a broader understanding of biology. Because once you understand the system, your decisions change, your questions change, and most importantly, your outcomes can change. If you've made it this far, you now understand something that most people never get fully explained. And that knowledge alone can be the difference between reacting to disease and actually preventing it. If you want, I can next.